Lovely. Hello and welcome to this Learning at Lunch session. I'm glad you could join me. Hopefully you'll be able to watch the recording if you weren't able to make it, and hopefully you can hear me. It'd be a bit annoying if you couldn't. Okay, so today we are going to talk about tracheostomies. So let me just move my screens around a little bit and share this screen. Just bear with me a second. There we go. So let's talk about tracheostomies. So if I share my screen, hopefully you will be able to, actually, let's just go there. Yeah, so hopefully you can see this. So the types of tracheostomy tube we have are very varied or can be. They tend not to be in ITU, but you may hear of some different types of tracheostomy tubes. So really, I'm going to just quickly run through the different types that we might have. Now, the one that you're going to see most often are the cuffed double cannula tubes. So you can see up here in the top left corner that a cuffed tube has a soft balloon around the distal end, and it's needed when there is positive pressure and it minimizes aspiration. So if the patient is on a ventilator and you don't have the balloon inflated, then that ventilator will just blow air up rather than into the patient's lungs. The same reason we have a balloon on an ET tube. Got to be careful with these because if the lumen is occluded, the patient will not be able to breathe, obviously. So the three questions you want to ask yourself about the types of tracheostomy tube: does it have a cuff or no cuff, in a cannula or not, or holes or no holes, otherwise known as fenestrated tubes. So uncuffed tubes are usually on long-term patients who are going to require ongoing suction. Now, they do have to have an effective cough or gag reflex. And you'll often see that on the patients that are on the wards and maybe perhaps have a long-term brain injury, are able to breathe for themselves, but don't clear their secretions particularly well. So they can have an uncuffed tube. They are effectively breathing for themselves, and the uncuffed tube is there to provide them with A, an airway, and B, a means of suctioning them. So let's talk about the double cannula tubes, which is probably what you're most used to seeing. So this is where there is a removable liner to facilitate cleaning of secretions. So you know the ones that we get where you twist them and you pull the liner out and then you can clean it and or put a new one in. So the spare inner tube should be kept by the patient and the inner tube should be cleaned every 6 to 8 hours. I'm not sure what our policy is, but that's certainly what the guidelines say. Now, what's a fenestrated tube? So a fenestrated tube has got a number of holes around down the actual tube itself. This again can be cuffed or uncuffed, and it allows air to pass and produces a more effective cough. You still need to perform suctioning with the fenestrated tube. And there's those openings allow air to pass and allow the patient to start to get used to air coming actually via the vocal cords and their mouth. I don't see them being used so much these days, certainly not in our intensive care. There is an increased risk of oral or gastric contents being aspirated as well, especially if they are an uncuffed tube. So probably don't see them in our ITU very often, but you may come across them from time to time. And then you have single cannula tubes. Now, the single cannula tubes are certainly less complicated than double cannula tubes, and they've got a larger inner diameter than the double cannula tube. So they offer lower resistance to the patient actually breathing out, and these can be cuffed or uncuffed. These are often used, you sometimes see them, they're what they call silver trachea tubes. They're not actually silver, they're just metal. and they can be used on very long-term patients. You'll sometimes see them on the laryngectomy patients, and a laryngectomy is very different from a tracheostomy. If you've had a laryngectomy, you've had your vocal cords taken away, and now your nose and mouth do not connect to your lungs anymore. It stops up here somewhere. So the laryngectomy and the tube in there is the only way of them breathing. And the key point to that is if their laryngectomy blocks, there's no point trying to bag them via their face and nose because it's not attached to their respiratory system anymore. So, what factors influence the choice? Well, respiratory function. So, if they're on mechanical ventilation, they're going to need a cuff. If they've got abnormal airway anatomy, so if they're obese, if they've got a fixed flexion, either their neck won't move. It could be for airway protection and weaning problems. You know, those patients we can't get off the ventilator, we take them tube out and then we have to put the tube back in again and out and in. Well, rather than doing that when you're trying to wean them, you give them a tracheostomy. You can then wean them much more slowly. And if they need to go back on the ventilator, then it's not a question of reintubating them. You've got the trachea there. It's nicer for the patients because they have the opportunity to speak, especially if we put a passing muir valve in. It's more comfortable for the patient as well because they haven't got a big tube stuck in their mouth. It's in their neck, which initially may feel uncomfortable, but they will get used to. So the different types of tubes there, we mainly used cuffed double cannula tubes. We'll perhaps start with an 8 or a 7, and then gradually we'll reduce the size of it. So there's more air going around it once the cuff is actually let down, which means the patient can start to speak. So what are the indications for a tracheostomy? There's a number of indications, really. So it's to secure and maintain a patent airway in upper airway obstruction. So if there's an obstruction up here, you put a tracheostomy in, then you're bypassing the obstruction. To maintain an airway in patients with injuries to the head and neck, to facilitate the removal of bronchial secretions where there's a poor cough, to protect patients at high risk of aspiration, i.e. those with neuromuscular or head injuries. It enables long-term ventilation if that's what's required. And for us, it facilitates weaning from the ventilator. Now, there's pros and cons. So the cons of an ET, it's unpleasant. You need prolonged sedation. You need to reintubate to reinstate ventilation. It can cause upper airway trauma. You get damage to the vocal cords. Breaching the larynx risks aspiration, and it can become blocked and displaced. There are, of course, cons of the tracheostomy tube as well. It's an invasive procedure. So, the patient needs to be asleep and we're stabbing a big hole in their neck. You can get bleeding and airway loss during the procedure. For those of you that have seen a percutaneous tracheostomy, you can see that we'll gather around with the bronchoscope and various pieces of equipment, and it can go wrong. And you have to be ready for that. The stoma itself, so the entrance of the tracheostomy, can become infected or break down, and it can cause scarring. They get something called tracheomalacia and stenosis. So that's just a wearing of where the tracheostomy tube was, which can cause them long-term problems. It can become blocked and displaced. You have to be aware of that. And it can cause damage to adjacent structures, or it can cause nerve damage as well. So, it's not an ideal thing to do, but sometimes we're left with very little choice. Hang on, I'll just get this. So, suctioning. Why do we need to suction the tracheostomy patient? So, the mucus blanket itself, so you've got something called the mucociliary escalator. So your nose and your trachea produce mucus from goblet cells, and they have cilia that waft up anything that's caught in that mucus. It's coughed or swallowed, and it's humidified as well. So if you breathe in through your nose with its rich blood supply will humidify that air very, very quickly and also warm it as well. Now, if you're giving them something via a trachea and you're bypassing the nose and the mouth, you're losing the humidification, you're losing some of the warming as well. So the loss of this mucus blanket means that you can get more secretions. Because of perhaps some surgical inflammation, you can get these more tenacious secretions as well because of the inflammation. The tracheostomy tube itself, where it sits, is paralyzing those cilia, and you've lost the normal ability to cough as well. We have to be careful with suctioning because it can cause hypoxia. It can cause cardiac arrhythmias. Um, it can cause atelectasis, so some blocking of the main airways, and it can cause trauma and infection. So we do have to be careful when suctioning. Don't do it too often if you don't have to, but if you have to, you have to. So, what are the indications? So, noisy respirations. So, you can hear those secretions. Increased respiratory effort. All of a sudden, the patient is finding it hard to breathe. The saturations have dropped. Perhaps they've plugged off one of their main bronchi. There's an increased or ineffective cough if they're able to do that. Increase of intercostal muscles. So, you can see the chest moving out even harder. They become hypoxic or they get cardiovascular changes. So perhaps they become brady or tachycardic, or the patient just says, I feel I need to cough something up. Catheter selection. These days we use I can't remember what it's called, the inline suction. And we just need to be careful that if it's too big, it can cause damage. And if it's too small, you might be making repeated attempts to clear the secretions. So the diameter of the catheter should be no more than half the internal diameter of the tube. And the internal diameter of the tube is the number that's on the tube. So 7, 8, 9 millimeters. Okay. There's two ways of suctioning them. So we can go shallow or we can go deep. So if we go shallow, we are going to go down to just the tip of the tracheostomy tube, and it maybe that's all that's needed. I don't know why I've written this in this color because I can't read it very well. Or it might be deep, so we could be going as possibly as far as the carina. And if you do hit the carina, just withdraw slightly before you start suctioning. If you hit the carina, it's going to make them cough, 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 cough. And watch your pressures when you are suctioning as well. So what's the process for suctioning? So set your suction pressures. I can't actually read that. Oh, wash, gloves, apron, goggles, possibly. Make sure the inner tube is appropriate. Pre-ox if needed. So be aware that if they do tend to drop their saturations, perhaps give them that little bit of pre-oxygenation first. Connect the suction catheter. If it's inline, you don't need to do that. Then you don't remove the trachea device. I don't know why I've written that there. Sorry, what I mean is you actually remove the attachment to the ventilator. Introduce the suction catheter without applying suction. So don't be sucking as you go down. And then occlude the suction port. This is if not using the inline. And then basically you're going to be pressing that little button and just suctioning them on. And make sure that you watch the patient throughout. You don't want any of those adverse signs to occur. So humidification. So dry oxygen should never be given to somebody with a tracheostomy or laryngectomy. Like I said, the nose humidifies it. The cilia in the mucous membranes all help with getting up those secretions when we breathe normally. We've bypassed that. So if we give them dry oxygen, you're going to cause retention of secretions, impaired mucociliary transport. So the mucociliary escalator that is working distal to the tracheostomy tube, that's going to get dry and won't work. You can cause inflammatory changes and necrosis, inflammation, ulceration, bleeding of the airway. You're going to reduce their lung function, and there's going to be increased risk of bacterial infiltration. So the number of different types of humidification, and this is the humidification ladder. So this is what the guidelines say. So we can start with the HME or the Buchanan bib, or when we used to use the Swedish nose, the Buchanan bib is just one of those things that goes over the tracheostomy tube that you sometimes see patients wearing out on the wards. We don't tend to use them in ITU. They're all aiming just to conserve heat and moisture. The Buchanan bib has a foam layer which absorbs moisture from the patient's expired gases, a little bit like the HME, really. Next step up, we perhaps need to give them some saline nebulization. The nebulizer converts the saline into an aerosol, give it via the trachea. It helps reduce the viscosity, making secretions easier to remove. And if the patient needs oxygen, then obviously it shouldn't be given via air. Next step up, we can do something called cold humidification, which bubbles gas through cold water. It only delivers 50% humidification, though. Warm water will hold more, will humidify better than cold water. So then we move up to the heated humidification. This actively increases the heat and water vapor of the oxygen, and therefore can be delivered fully saturated. And it's indicated for those patients receiving mechanical ventilation or oxygen therapy for more than equal to or more than 96 hours is what the guidelines say. So they're the various steps. I think we pretty much use heated humidification for all our early trachea patients and then work our way down. So what about managing the inner cannula? So secretions can adhere to the internal lumen of the tube. That increases the work of breathing, and cleaning obviously aims to reduce those secretions. So it should be removed and inspected at least 3 times a day, or if the patient is showing any signs of respiratory distress. Clean it with sterile water, which is then disposed of. And the primary function is A, to remove the debris, and the secondary outcome is the reduction of bacteria. So obviously, if you're cleaning it, you're not leaving a membrane of secretions on there that the bugs will love to grow on. Then hopefully you're going to reduce the chance of the patient getting an infection via that tube. So remove the tube, clean and replace. If it needs cleaning, insert the spare inner tube. Clean it with a foam brush or gauze, leave the tube to dry in a suitable container, and then just make sure that you reassess the patient. Tracheostomy red flags. Now, these are important. So by red flags, I mean something is wrong. We need to do something quickly. Okay. So you've got airway flags, breathing flags, and specific tracheostomy flags, and then general flags. So airway flags. With a cuffed trachea, no air should escape through the mouth. If the patient's talking, or you can hear audible air leaks or bubbles of saliva, these all indicate problems. Okay, so probably means that your cuff has either herniated up, so it's come up above. Well, it can't come up over the vocal cords, but it's just herniated and moved to the side and created a gap. Or that there's a leak in there and it's deflated slightly. And you'll know that because you'll inflate it and it just won't stay up. It will just gradually go down again. Or if you get any grunting, snoring, or stridor, so that could indicate that there's an obstruction somewhere in that tube, whatever it might be. And you might need to take out that inner tube, replace it with the other one. If that grunting, snoring, or stridor doesn't get any better, then it could be that it's actually an airway problem rather than a trachea problem, but you certainly need to explore it. The breathing flags, obviously, if the patient becomes apneic, stops breathing for whatever reason, or if there's any difficulty in breathing, which would be indicated by excessive muscle use, increased respiratory rate, higher airway pressures, or lower tidal volumes. Do they become hypoxic, or any whistling noises or noisy breathing? All of those might indicate that there might be secretions down there, there might be some obstruction, the tube might have moved, the tube might be about to come out. Just keep your ears open for things like that. Specific tracheostomy flags, visibly displaced tubes. Now, I had a patient about 3 months ago who had a type of tube that I wasn't used to seeing. He'd had it for quite a long time, and then suddenly he told me that he had difficulty breathing. There was this much of the tube out here, so that way, this much out. But I didn't know, because I wasn't familiar with this tube, whether that was normal or not. And in the end, because he was close anyway, we decided to remove the tube. And actually, when I removed the tube, there was a very tiny little bit of it left in there. So the patient telling you that his breathing doesn't feel right needs to be taken seriously. And that's what he was telling us. And he was very pleased to have the tube removed anyway. You need to check for blood or blood-stained secretions. Hopefully, there might be some initially. There might be very small amounts, but if these become persistent or get worse, then that's something else that we need to explore. If they start to if it starts to become more comfortable or more painful, or as I said earlier, requires a lot of air to keep the cuff inflated. And then the general flags, really, the kind of things that you would be looking for normally. So, are there any changes in the heart rate, the respiratory rate, or the blood pressure? Any changes in level of consciousness? Any anxiety, restlessness, agitation, or confusion? And those are all the things that don't just apply to tracheostomies, obviously, but it's something that you need to be aware of and keep a lookout for. So, emergency tracheostomy management. This is from the Resus Council, I think. So if you're concerned, look, listen and feel at the mouth and the tracheostomy. So perhaps attach that water circuit. Make sure you've got capnography. If you've got capnography, then it could be it's a good indicator that you are getting some breathing back from the patient. So is the patient breathing? Yes. You would apply high flow oxygen to both the face and the tracheostomy. So you're going to give it there and you're going to give it there just in case there's an issue here. Remember that they still have the connection between the two. If the patient's not breathing, CPR, call the resuscitation team, or put out an alert. You then need to assess the tracheostomy patency, whichever one you've done. So if necessary, you remove the speaking cap or valve and remove the inner tube. Can you pass a suction catheter? Yes, if you can, then the tube is patent, so perform secretion. Consider partial obstruction, perhaps reventilate them, and look at an A to E assessment. If you can't pass a suction catheter, then that cuff comes down. Look, listen, and feel at the mouth and tracheostomy. If the patient is no longer improving, then you need to remove the tracheostomy tube and put a mask over their face. So we need to perhaps use the Mapleson C or the water circuit, the green one, with a mask over their face. Somebody will need to occlude the hole over their neck, and you're going to need to bag them and start ventilating them that way. Now, if you can't do that, then again, hopefully you'll have the emergency team there. So the emergency team will start doing things like oral airway maneuvers. So using the bag valve mask, perhaps putting LMA in, or ventilating via just the stoma to see if they can get any air through that way. It may be that if none of that's going to work, then the patient needs to be intubated via the oral route. Or if worst comes to the worst, you might think about considering intubation of the stoma itself. If you can't get in up here for whatever reason, they might think about putting a very small tube, a 6, a 5, a 4, whatever you can get into that stoma to ventilate them. Now, I'm not going to go into laryngectomy management, but basically the main difference is that there is no point bagging this patient from the top there, as I've already said, because they have no patent airway. It won't do any good. If you're going to do any good, you're going to be going there. We don't get many laryngectomy patients on ITU. They tend to stay out on the wards. But just in case you come across one, hopefully they've got a sign behind their bed saying they've got a laryngectomy so that you're aware of that being an issue. And that's it. So that's tracheostomy care. Keep coming back. We will keep doing these for as often as people like. And hopefully I will see you at the next one. So thank you very much.